So Dr. Athreya is the lead interventional radiologist at St. Joe's Healthcare here in Hamilton. He has been a staff radiologist at St. Joe's Healthcare / McMaster University since 2008. He has recently been promoted to Associate Professor, Faculty of Health Sciences at McMaster. I would like to thank Dr. Athreya for coming because the radiology part of managing kidney cancer is extremely important. So I'm going to turn the mic over now to Dr. Athreya to share his information. Thank you.
Thank you. Thanks for the introduction. Thank you. Good evening, everybody. So the next 20-30 minutes, we'll just do a run about the scans, what do they mean, and just some basic knowledge about the CT scan, the MRI, and ultrasound scan, and just very briefly discuss what's a biopsy and what's tumor ablation, which is a non-invasive treatment for certain types of kidney cancers. I know we've got a lot of questions, particularly from the previous speaker, but I'll try to address as much as I can, but I'll take questions in the end. So what is ultrasound imaging? Some of you might have had ultrasound imaging. It's a safe, immediate first point of access for any kind of kidney problem presentation. It doesn't involve radiation. What it involves is an ultrasound waves, which is non-invasive, not harmful to the patient. Usually, the probe is run over the region of interest. The probe or the transducer, what we call, emits sound waves, which gets traveled through the body, reflects on the organ of interest, and sends sound waves back, which is collected by the transducer to the computer, which generates images and are read by the radiologist. The advantage of ultrasound is the images are captured in real time. So what are the benefits and risks of the ultrasound diagnostic test? It's, again, as I said, it's non-invasive, doesn't involve needles or no IV access is required. It could be temporarily uncomfortable when the probe is run over the part of region of interest, but never painful. It's widely available. It's cheaper compared to MRI and CAT scan, and again, it's less expensive. It's extremely safe because this does not involve radiation, because it provides real-time imaging that helps in intervention radiologists like myself in guiding needles for procedures such as to take biopsies or aspirate some fluid or tumor ablation, which I'll explain later. And again, there are no harmful risks of this procedure because there's no radiation involved. CT scan. What is a CT scan? It's commonly referred to as CT scan or sometimes CAT scan. It's again a non-invasive medical diagnostic test. Unlike standard X-rays, it involves providing multiple images through So unlike the traditional X-rays, multiple images are generated through CAT scan. I'll show the picture of how the images is generated in the next slide. These images are reformatted in different planes and helps radiologists to make a diagnosis and also come up with a staging. As you're aware, these images are viewed on the computers or could be printed on films, which are probably not performed, or it could be transported on CDs. Why do we need CT scan? First of all is to make a diagnosis of what the primary condition is and to stage the disease, obviously, and it helps in guiding the right treatment for the right stage of the disease. And CT scan, as I explained, also helps in guiding needles to help us in taking fine course from the tumors. CT scans are also needed for follow-up of treatment, either after surgery or after tumor ablation, after chemotherapy and radiation. So I think I don't need to show how a CT scanner looks like. So that's the X-ray tube, which generates X-rays, passes through the body. There are detectors on the other side of the tunnel, which generates images processed by the computer and read on the X-ray on the computer screens. This is the picture of an injector to inject the X-ray dye. And again, I'll explain to you later why contrast is required in certain cases. How is the CAT scan performed? Usually the patient is positioned on the table. They're lying supine, meaning lie on the back. Again, pillows and straps are provided to maintain a still position. You'll be asked to hold the breath because breathing will cause motion artifacts, and that will impair the quality of the images. A contrast material will be required, which could be administered either by IV cannula, which is put in before the procedure, or sometimes oral contrast might have to be used as well to delineate certain structures within the abdomen. Once the scanning is done, the technologist verifies the images, make sure it's of standard quality, and the patient is sent home after removing the IV cannula. So who interprets the results? It's radiologists like myself, interprets the CT images, go over the scans in detail, which are reformatted in the axial plane and the coronal planes. The reports are we usually send a signed report. In my institution, usually the report turnaround time from the time the scan is done to reach either the family physician or the referring clinician is about a week. And the reports are discussed either by your family doctor or by the referring clinician. What are the benefits and risks? First, let's go with the benefits. CT scan is non-invasive, it's painless, it's quick, easily accessible, and available for quick diagnosis. The advantage of CT scan is you can look at the images of the bones, the blood vessels, the soft tissues within the body at one go. And as I said, it's fast and simple compared to MRI examination, which I'll come later. What are the risks? So we did discuss about the radiation, which is the main risk of the CT scan procedure. The risk of exposure, radiation, is usually measured in millisieverts. For one CT of the abdomen and pelvis, there is the radiation dose, effective dose given to the individual is about 10 millisievert. What does it mean? It means having at least 3 years of natural background radiation. That's what it amounts to, one CAT scan. But the risk of cancer with this is low risk. The risks are categorized as very low, moderate, or high risk. With a CAT scan of emitting this amount of, giving this amount of radiation to the patient, the risk of cancer is low. And again, the benefit of the procedure or the diagnostic test outweighs the risk. What about the contrast material? Sometimes the iodine content in the contrast can cause allergic reaction. All the radiology departments are well equipped to deal with allergic reaction. Sometimes if the patient already has had reaction in the past, they will be prepped beforehand with Benadryl and steroid. Each department has a certain protocol which they follow before the CT scan is performed with IV contrast. Again, IV contrast cannot affect the kidney function, particularly if the patient has a pre-existing kidney failure. So it depends on the degree of kidney failure the individual has. Based on that, either the patient gets more hydration prior to the scan is performed, or certain will have to discuss with the nephrologist depending on the amount of kidney function and weigh the risks and benefits and proceed accordingly. What about MRI? MRI, again, like CT, is non-invasive test. How is it performed? MRI is mainly performed with the radiofrequency pulses, which are emitted within the magnetic field in the magnet or in the magnetic bore when the patient is on the table. So these images are again transmitted by computers onto the monitor, which are kind of generated, many sequences are generated which are reformatted by the technologist, which is called post-processing, and then forwarded on to the radiologist for reporting. Advantage of MRI, does not use ionizing radiation, unlike CT scan. It looks like a CT scan again, but the tunnel it's quite narrow, and it's a long tunnel inside. And some of the patients might have claustrophobia with the MRI scanner compared to the CT scanner. Similar to MRI, patient is positioned on the table, use of bolsters and pillows to position the patient. Breath hold is also again required during this test. MRI uses a different type of IV contrast. It is gadolinium based, unlike iodine based in CT scan. This gadolinium does not affect kidney function. However, studies have shown if the patient has a pre-existing kidney failure, use of gadolinium can cause some certain systemic fibrosis. It's called non-systemic fibrosis. It's thickening of the skin and might affect different organs of the body, but again, it's very, very rare. It was only seen in certain gadolinium contrast agents which were used earlier, during the earlier days, 10, 15 years ago, but most of the contrast currently available do not, or there's a very, very low risk of NSF following use of gadolinium in patients with pre-existing kidney failure. Unlike CT, MRI involves multiple sequences, multiple runs within the MRI scanner. That's the reason why MRI scanning takes longer time compared to CT. The examination may last 30 minutes or sometimes over an hour, depending on the organ image, and most in this case, for an examination of the kidneys, it will be at least between 30 to 50 minutes. Again, the benefits of MRI is non-invasive technique. It does not involve radiation compared to CT. Contrast used in MRI, the gadolinium-based contrast, is very unlikely or less likely to produce allergies or affect kidney function. And MRI has slightly advantage compared to CT in terms of differentiation of the soft tissues compared to CT. And again, the risks. MRI examination performed with standard technique and standard protocols very rarely has any harmful effects on the patient. And again, contrast allergy is very, very rare. I'll just move on to renal lesions, talk about what is a cyst means, what's a tumor, how do we differentiate on various scanning we perform. What is a cyst and what is a solid lesion? A cyst is a thin-walled lesion. It's filled with fluid, and it's when we give X-ray dye on CT scan does not light up. That means usually the tumors have increased blood supply. By giving contrast, the contrast preferentially enhances the tumors much more than the native organs. That's the reason why we give contrast. The cyst does not enhance with contrast examination. And the best test to differentiate between a cyst and a solid lesion is ultrasound examination. What about a solid lesion? Solid lesion, as the name itself says, it's solid. It's got soft tissues within it, unlike a cyst. And it enhances, meaning it lights up with the X-ray dye given either by MRI or by CT scan. Ultrasound, again, differentiates between a cyst and a solid just by saying that, yes, it doesn't look like a cyst because it's got solid component within it. And again, solid lesions can be locally aggressive if it increases in size, or it can spread to other organs, either by lymphatic, which means spreading into the lymph glands, or by spread by bloodstream into the liver, bone, or the lungs. The renal cyst has its own staging or classification depending on how thick the cyst wall is, if the presence of calcification within the cyst, or if the cyst wall enhances on a CAT scan or MRI examination. It just various stages, from stage 1 to 4. I don't want to get in detail, but stage 4 is the one, a cyst which is complex. That means it's got increased vascularity, meaning it's got more blood supply, which is usually seen on CT scan or MRI. How is this diagnosed? Most of the time, the patients have an ultrasound examination for a follow-up of a cyst. And if the ultrasound examination confirms, yes, the cyst looks complex. That means it doesn't have the thin wall like a stage 1 cyst. It has got calcification within it. It looks complex. That's when the patient proceeds for a contrast enhanced examination. Most of the time it's CAT scan, very occasionally MRI, if a complex cyst cannot be differentiated between a tumor or just a complex cyst. This is an unenhanced MRI examination. You can see on the left kidney there are 2 lesions. It's hard to say which is a solid and which is a cyst. By giving contrast on MRI, the one which it is clean, thin wall, which lights up, that is a cyst, and one which has got solid component, which has some irregular enhancement. That means the dye shows irregularity. That is a kidney tumor. What about this? This is a CAT scan of a patient which has got a huge mass within the left kidney, which is on staging. It comes to almost a stage 4 kidney tumor. Which imaging is best? It depends on the symptoms and what the presentation is to the family physician or to the urologist. It could be abdominal pain, or a mass might be felt, or it could be blood in the urine called hematuria. And again, what's the suspicious of after examining the patient or taking a detailed history? What is the kind of suspicion? Is it a tumor or is it something else? And also the access to imaging. Which imaging modality is easily available? Most of the time it's ultrasound, which is easily available. Next would be CT scan. Most of the time, what in my practice we see is patient would have had ultrasound examination, and then something is picked up on ultrasound examination, and then proceed for further imaging based on the ultrasound report and the presenting symptoms. I'll just briefly discuss what is a biopsy. A biopsy is a procedure where a needle is inserted through the skin, either under ultrasound guidance or under CAT scan guidance, to the lesion, to the target or the region of interest, and core samples are taken. This is a minimally invasive or less invasive procedure. They're almost always performed under local anesthetic, which is freezing, and the procedure is performed as an outpatient procedure. The patient usually come in, usually in the morning, the procedure is done, and discharged usually 2 to 3 hours after the procedure. This is a picture of a biopsy performed under ultrasound guidance. The bright line here, what you see is the needle, and here's the kidney tumor. I think it's hard to see in one image. This is what I meant by ultrasound, which is real time, helps in guiding the needle to the target. Staging of renal cancer. It's worldwide accepted, the American Joint Committee on Cancer, which is the TNM staging. Again, T meaning for the primary tumor, various stages starting from TX to T4. It again depends on the size of the tumor and also how much it is spread locally. What about N? N means for the lymph node. Again, presence of any enlarged lymph nodes in the region of the kidney or beyond it. It has its own, either N0 meaning no lymph node involvement, N1 meaning it has some lymph node involvement. M is for metastasis. That means the cancer has spread beyond the kidneys. It could have spread to the liver, to the bone, to the lungs, or any other organ apart from the kidney. Then you call it M1, which is distant metastasis. The staging is again from stage 1 to stage 4, early stage 1 to stage 4, which is distant metastasis, or it could be locally aggressive tumor. So decision making. How do we decide the the treatment. First of all, you need to have a diagnosis. And diagnosis could be CT scan or ultrasound or MRI. Most of the time, or if not all the time, a biopsy is performed to confirm what is the suspicion, and also to know the type of the renal tumor and the subtype of tumor, which can help the urologist, the oncologist to guide the right treatment for the right stage. What are the treatment options? I don't want to discuss the conservative treatment or the observe, wait and watch, or the operative procedures for certain types of kidney tumors. I'll very briefly discuss about the non-operative, minimally invasive percutaneous technique, which is the tumor ablation, which are performed by interventional radiologists. Ablation is a Latin word, ablatio, meaning to take away, and in the current, what we do in the medical intervention means a removal or reduction or erosion of the abnormal tissue from the body through cell death. It is a minimally invasive, non-surgical pinhole procedure similar to a biopsy, and there are various forms of tumor ablation. It could be thermal, meaning applying heat or cold, or a microwave ablation, chemical ablation, or IRE, which is irreversible electroporation, which is under research. So what is radiofrequency ablation, which that's what we offer at St. Joe's. I'll just briefly explain what an RFA, or the radiofrequency ablation, means. It's again a minimally invasive technique to treat certain types of kidney cancers only, and it's image guided, most of the time performed under CAT scan guidance. It's similar to biopsy, and it's performed by interventional radiologists. How does it work? It means introducing a needle similar to biopsy under image guidance through CT. Most of the time it's CT scanner. The needle is placed into the tumor. The needle is connected to a generator, which is this. The generator generates the high radiofrequency current, which generates really high temperature up to 100 degrees centigrade at the tip of the needle, which is within the tumor, and burns the tumor, causing coagulative necrosis. When do we use RFA? When do we treat them? The tumor size should be less than 4 centimeters. Patients having a single kidney, removing a kidney will affect the kidney function. Patient will have to be on continuous or chronic dialysis. Certain medical conditions make the patient unfit for surgery, or the patients might have difficulty to recover after a prolonged surgery to remove a tumor. And certain tumors with a familial disposition, particularly von Hippel disease, might have recurrent tumors. These are the indications for performing a percutaneous radiofrequency ablation. Just showing a couple of CT scanners. This is the scan on the left shows a rounded, approximately 3 centimeter tumor in the kidney, and that's the radiofrequency probe placed within the kidney. This is another patient, a solid lesion within the posterior aspect or back of the kidney. That is a probe, a radiofrequency probe placed within the kidney, within the lesion. This is what we find immediately after the procedure is performed. And this is a follow-up scan performed 9 months after the procedure. Here you can see the rest of the kidney shows enhancement with the contrast, and the ablated or the burnt zone does not show any enhancement with contrast, indicating a disease-free at this stage. How do we know whether we have performed the right treatment? How do we follow these patients after ablation? Most of these patients have CAT scan again. They're performed usually between 3 to 6 months in the first year, and again annually after that. And again, it depends on what we find on the follow-up CT scan within the first year. And the second year, the follow-up could be either MRI, or sometimes we do perform ultrasound contrast follow-up. What are the benefits of RFA and risks of RFA procedure? Radiofrequency ablation is relatively quick. It's performed as a day procedure under conscious sedation. General anesthesia is usually not required. It's less expensive and suitable for small tumors of the kidney. And most importantly, it preserves kidney function because the kidney is not removed. It's only the tumor, and part of the kidney surrounding the tumor is burnt. What are the risks? Bleeding and infection are most commonly like any other procedure. Very occasionally, if the tumor is adjacent to the liver or the spleen or the bowel, there is a chance that they do have some thermal effects, but there are various techniques to prevent this. Incomplete burn and recurrence is a risk of this procedure. Radiofrequency ablation, based on the published report, radiofrequency ablation compared with partial nephrectomy, meaning removing just part of the tumor, leaving the kidney behind. Surgery is always a gold standard. Radiofrequency ablation is considered almost on par with surgery. Partial nephrectomy as over 95%, 5 years disease-free interval. Radiofrequency ablation falls short of it. It comes to about 92 to 93% based on the published literature, but again, it's pretty close compared to the surgical limb. That's it. Thank you for your attention.